stick your hand up and we'll get someone to you. Oh, that's good, because normally there's a great silence at this point, and there's a gentleman here with a red tie. Yeah, just say who you are for us, would you mind?
Alex Lewis, I'm Medical Director at CNWL.
I think we missed your name, sorry.
Alex Lewis.
Thank you.
It's just to reinforce a point that Tony made right at the very end, and a challenge to the panel. A comment made in the evaluation of the inner northwest London was the referral that the partners were to community hospitals. I assume it was organisations or trusts, and it's a challenge to the panel. Have we actually changed our mindset in referring to care being delivered in hospitals? Has there really been a change in the mindset and a cultural change?
Just say a little bit more about the sort of change you're expecting.
Well, I think personally that we in a lot of work that we do, we constantly refer to care being delivered in hospitals. I'm not sure that the mindset has actually changed to deliver what Tony made reference to, particularly in his last bullet point.
Okay. Who'd like to take that on? Tony, that sounds like one for you.
Oh,
Just, I think so.
Well, I would agree with that. I think we've got to personally park what our past experience of titles, labels like acute hospital, DGH, community hospital, just forget it and say, where does this care best need to take place? And also suspend the belief that acute hospitals are all bad at all times or spend a lot of money.
That's a radical view.
Very radical, yeah. I know. But, you know, sometimes you need them. And so when you need them to be really good at what they're meant to be doing and really effective. And therefore, we need to protect the whole system. And so I'm with you on that. I think we should just accept that care needs to take place where it needs to take place and not have any preconditions about what the title is.
Yeah. Judith? Other panel members?
Just to say that I agree, because I think it's all too easy to spend our time in programmes such as this, almost coming up with workarounds for the different organisations we've got, and the way, you know, it's difficult getting patients or users, you know, through the system. But I think it's back to the point that I think Thurza made right at the beginning, and I think I made it as well, about this always taking yourself back. When I say to the user or the patient perspective, we're all users or carers, actually, and I'm sure there's many of us in the room who are caring for frail older relatives at the moment. And I think, you know, we all know that when we're in that position, even with all of our knowledge about health and social care, we're not thinking about it, about the organisations. We're thinking about the fact that you know, my mother-in-law with dementia, you know, is she safe today with the carers there? Do you see what I mean? It's that personal bit. So I think that in this work, and I think this is what's so important about the time you're putting into co-design and being reflective about what it is that you're about, and working, as I understand it, very closely with patients and lay and community groups, is just critical, because I think otherwise we will just keep trying to fix the system as it is and not come up with something that actually often may actually be simpler than what we've got.
Phil, did you want to?
Yeah, can I build on that? Because I think one of the points is that we need to look, part of this is about looking beyond care, isn't it? And I think going back to I've had the benefit of looking at the case studies in detail, which were in the video. And actually one of the things that was underpinning the issues for the first person was not actually about care at all. It was about social isolation and financial insecurity. And I think that builds on your point that it's not only about care in the traditional sense, it's not only about medical care or adult social care, it is about putting in the kind of things that make a difference to people's lives and improve their quality of life, which has this knock-on, I think, into the health and social care system.
I was wondering whether your point was rather more pragmatic, which was mindset in terms of do you discharge to decide what you're going to do? You admit to decide what you're going to do next, or do you admit because you've got a purpose? Do you are you discharging because we suddenly need a bed, or is it part of a plan? Do your ologists work, do a traditional outpatient clinic that we've done for 50 years, where about this number of people sit in a room and see a doctor for 2 minutes, at regular intervals with no apparent underlying clinical purpose. I wonder if that was that was my interpretation. It may have been it was wrong, but never mind. We can have that conversation later. I could go on. I won't. Let's have there's Claire here. This is the. Thank you.
Thanks very much.
Claire, say who you are.
Thanks very much. Claire Gerardo, Head of Transforming Primary Care for NHS London Region. Thank you very much. Fantastic talks. I've been busy working with NHS London looking at creating standards for primary care, standards set against what patients tell us they need and want, against access, coordinated care and proactive care. And in my travels, and I've been to a lot of places listening to integrated care, and this is fantastic, but I never hear similar standards for integrated care. I never hear of what you think good looks like. I do know the literature, and I know the fantastic stuff the Nuffield Trust have produced, but I never hear it. I never hear standards around care that continues for 48 hours post-discharge, a standard around, somebody mentioned it, but actually turning it into a standard around a shared electronic record, one single record, and then we have to work out how to do it. A standard around impact assessment as to what would happen when we move care into the community, what the impact is on the ability to deliver integrated care. And I wonder how far, with all of your thinking, you've got around creating what good looks like and can be defined.
That's a tough question. I think that's probably for you two to start with. Teresa, did you want to?
Yeah, you notice the way I'm just saying, Phil, do you want to pick that up first?
Well, I think, well, I'm not sure, because the outcomes work hasn't focused so much on standards as such, but what it's focused on, and I think, maybe a challenge to that question, is about how we embed a very personalised individual focus on this. So when a care plan is created, that looks at what that individual, what the barriers to that individual's quality of life are, what that individual wants to achieve, and then we have a way of looking at that 6 months down the line and saying, or a year down the line, has that actually improved? You know, are you more able to get in touch with your friends and family? Do you feel more financially secure? Are you able to live in your own home comfortably? And I think, so in terms of that population and outcomes work stream, that's how we've been focused. I think in terms of standards, my struggle is I think it's quite difficult to do that. And it comes back to the other point I made about the North West London approach, isn't it? And I think the approach we've taken is to set a challenge through the toolkit about the things we should be thinking about without being prescriptive about exactly what it is that you have to do locally. And I guess the question we've always had in the work groups is, should there be more red lines, if you like, which I think would equate to your standards? So are there some things that whatever you do locally, you have to achieve A, B and C? And that, I think, is coming through in the toolkits at the moment. I don't know if you wanted to have more, Teresa.
Well, I just wonder whether one of the issues here is that we often have got quite confused between the role of commissioners and the role of providers. And the UK approach to commissioning is to continue to try and manage the providers in detail. What you're describing is the commissioner saying these are the outcomes you want. How you achieve that, to some extent, is up to you. The providers themselves then do probably need some fairly rigorous standards, but it's probably on the whole not the job of the payer, the commissioner, to try and second guess the people who, you say we'll hold you to account for the outcomes for the patient. How the professionals from the different disciplines then develop their standards may well be an issue that you need to leave them to deal with, I wonder. Judith, did you want to come in? And Thursday, and then I'll come to you.
Yeah, just to say that for me, I wouldn't want to separate out standards for primary care from standards for integrated care. For me, scaling up, thinking about the sort of primary care we need for the future is fundamental to achieving this thing that I think we've got in our mind about that we call integrated care. That's the first thing I'd say. One of the reasons I say that is in some work that actually we at Nuffield did with the King's Fund, and Nigel and I led last year, where we were looking at future models of general practice. And I say general practice because it was that part of it. We came up with what we called some design principles. And the ones in there which were things like, if I've got multimorbidity, I will be able to rapidly get specialist advice and the length of consultation I need. I'm trying to think of others, Nigel. They were about rapid access to diagnosis. But it was effectively it was trying to express from the individual's perspective what good primary care would look like. For me, if you put those in place, you're quickly impacting on the rest of the system. What it is there, the role of the hospital and the specialists in supporting primary care, community services and social care and so forth. So I say for me, I think we need to keep those together. And just one other thing to add, some work that we're doing with the Picker Institute in Oxford is we're trying to develop some measures of what care fragmentation or coordination is like at the individual level, because so often we look at people's experience in hospital, in general practice, in social care, and we rarely track, using the data we've got, what happens to people as their experience as they go around the system. So I think that's some quite important detail. I know it's methodological, but I think it's actually very important work that we're doing at the moment and we'll be testing out. And I guess who knows whether it would be possible to test some of it out within North West London in the next year or so.
Thursday, did you want to come back on that question?
So I suppose probably only to sum up and not to swerve Claire's question that it's work in progress. So I think that being work in progress, we're trying to build on what we have that's good. We're trying to very much, and that is around the evaluation we've done of the care planning approach we've had so far, how we look at a whole system evaluation but recognise the components, parts within it, and come back to the outcomes for an individual, but able to aggregate that up. And Claire and I had a very brief conversation at another meeting where I think one of the standards is people who would benefit from coordinated care will have a care plan, leads to at least 20 discussions about who would benefit from coordinated care. So I think it is work in progress.
They agree on what a care plan is then?
Yes.
Good, and that's something. Jolly good. I can't see, there's a lady in a jacket, red jacket, waving at me, but someone's standing in front of her, so I can't. Yes, thank you.
Hi Nigel, it's Jackie Mallender.
Oh, hi Jackie.
Hi, from Matrix. I had a question of Tony Bell, and it picks up from something Nigel said earlier on. My question is this: from a provider perspective, as one of the early ACOs, probably the only ACO in the UK, how do you respond to Nigel's comment that the Commissioner should only be interested in the outcomes?
That's probably a slightly purist way of putting what I said, but yeah, but yes.
Yeah, I thought you were going to ask me actually to comment on about the waiting room full of people who don't need to be there. But to pick up the point on outcomes, I think the financial outcome, the fiscal part of this, goes hand in glove with the health outcome. There's no doubt about that because we have a resource within which we're all trying to live, and I think for all sorts of reasons we're saying that that needs to be managed very carefully, and we need to get the best outcomes possible. So I don't have a problem really with the Commissioner being engaged in both of those dialogues, but I think what they've got to recognise is the various actors in the system are also part of that equation. There are assets in all of those parts of the system. You can't simply dismantle one and watch it fall over and hope no one will notice, which we see. This is how hospitals go into crisis. It is quite often because there is a systemic problem, not simply a problem in the hospital. Hospital is the manifestation of where it sits, where it actually falls, whether it's staffing levels, it's queues of ambulances or whatever. It's a bigger system failure that's brought us to that point usually. So I think commissioners have to have an interest, but I would agree with them that they can't overprescribe, just as the Secretary of State can't overprescribe, what it is you're going to do today for someone with knee pain. And I think that, we have to be clear that the payer has to have some say in what they want to see as an outcome. But then it's the clinicians who have to say, so how do we do that? I think that in Spain what we saw was the clinicians, and I didn't show it on my slide, but we've set up a clinical subgroup. The clinicians have spent years working together on adopting common standards. I think if you work in a system where you accept there's a fixed payment and you want the best out of it, you've got to have common standards. And you can't do that simply by hitting one another over the head with your version of the standards. They have to be ones that get a patient with knee pain referred at the right time and to the right person with having had the right interventions prior to that you've all agreed on. So you all have to agree what good looks like, picking up Claire's point. I think the commissioners need to know that those pathways are being worked on and what the outcome of delivering them is. But I do think they should leave the providers to get on and do it, and that should be one of their expectations.
That's probably a better and more nuanced way of putting what I was saying. I mean, we certainly do see payers across the world involved in pathway development and in a number of these, and working with the providers on that. I think it's the British style of basically performance management by proxy that I think has been our problem in the past. I think we've got time for one more, which fortunately is just, well, we'll take two, because we'll take this gentleman here, and
the Chief Executive.
Steve, we can't hear you, sorry.
Ian Smith, Chairman and Chief Executive of Four Seasons Healthcare and Elderly Care Mental Health Group. The thing I struggled in the presentation was to see how the ACO from Chelsea and Westminster connects to the integrated North West London proposition. You know, there seems to me an inevitable tension between acute trusts as they've operated, the need for them to protect their budget to remain in business, frankly, on the one hand, and therefore the tendency for them to move towards an ACO which projects their responsibility outside of the hospital setting. A conflict with that when you come from it from the angle of adult social care or community care, with the wish to pool those resources and pull that money out. And I just, my question is there a tension between those two, and how do you plan to manage it between the four of you on the stage there?
Okay, great question. So, and we'll take one more question. I think there was a lady with her hand up over here. How are we doing for time? Yeah, we'll take two more. This quick question here, and there's a gentleman there, because I'm conscious I've been ignoring that side of the room because of the way I'm sitting, so I'll make that up. You I'm afraid, have had it. I'm sorry. I will get into trouble with the organisers. Yes, very quickly.
Thank you. Can you hear me?
Yep.
Mary Archer, I'm chairman of Imperial College Health Partners External Advisory Board. Thank you for a really interesting set of talks. My question really arises from Tony's answer to Claire Gerarda's question. I think it's essential to start small with something you can deliver it, and then move, as it were, onwards and upwards. But you do need to do so within a framework of supportive leadership, which you've provided in those systems. And that leads me to wonder about support and understanding of these initiatives at national and regulatory level. And I'm particularly thinking of Monitor, which still seems to me to have the emphasis on the performance of the hospital as a quasi-isolated system, and not to be sympathetic to thoughts about whole systems approaches.
Thank you. And then, if you could be brief for us, that would be helpful.
Yes. My question is about the toolkit.
Say who you are for us.
Jonathan Munday, I'm Vice Chair of Central London CCG.
Thank you.
My question is about the toolkit. I understand why we are concentrating on 9 groups. I wondered what the evidence base was behind those 9 groups, and precisely what percentage of the total budget is going to be covered by specialising those 9 groups, as opposed to looking more generally at the population.
Good. Okay. That sounds like a quick question. I'm not sure it really is, but that might be quite hard. Right. Great questions. Competition. National support and lead, and where that's coming from, and a complete rundown of the total evidence base for the 9 groups in brief.
So
Who'd like to take those on? Let's take the competition first. Yep.
So I think the point in terms of where we are in the programme is that we are looking for what Phil said were the early adopters of the ways that our existing providers could come together with proposals about how they would work differently. So we require commissioners to do that in terms of their commissioning budgets and how they would put that together, and then for our existing providers to respond to that. That's the stage of the programme that we are at. So Chelsea and Westminster's thinking has progressed further than that, but as a programme as a whole, that's where we are. We have generated an awful lot of excitement across North West London. by all providers, by our lay partners and by our commissioners about how that could be, and that's what we're working through at the moment. And Phil's point was very important in terms of going back to what were the principles we were looking for in terms of how we would get the real change that we needed to have. And then just to pick up on the second point, we weren't quite sure why we wanted to be a pioneer. We wanted to be a pioneer because it was a way of bringing all of us together and getting a momentum going. What is becoming clear is that there has been the potential to relaunch Pioneers in relation to being able to challenge some of the barriers that there are in the system that's working against us. And certainly at a meeting I was at last week with Norman Lamb, he was talking very much of if we are encountering those problems at a national level, then we need to use our pioneer status to start saying how we would challenge them and how we would work differently with them. Doesn't mean that the solutions will be easy, but I think we have an open door to have some of those conversations that other people don't have. And part of that commitment now from the integrated care partners nationally is that each pioneer partner will be given a board level representative from one of the partners, so Monitor or the TDA or NHS England, to be effectively our sponsor and to help us with those conversations. So I feel more encouraged now than perhaps I did a week ago that we can address some of those issues. I'm absolutely going to leave the answer in relation to population to someone else.
Okay. Tony or Phil, do you want to take?
Can I just pick up before I go on to the population, the tension one? And I think there is a tension, but I don't think the only tension is with the acute trust. I think there's a tension. I mean, at the programme board last week, I was hearing from a GP about their concern about moving to this capitated budgets and what does that mean for a small provider. I think there are tensions across all of it. And if you go back to what you were saying earlier, if the future looks fundamentally different from today, I think there are risks for all of our organisations, and to pretend there aren't it avoids the central challenge. So I think, you know, where we've taken it in Brent was when we sat down in our what was the Integration Transformation Board, is now the Better Care Board. You know, the starting point was there is no new money in the system. We have to take money out of the system. We have to deliver better outcomes. Let's be honest about that, and that's going to have a different pull in different directions, the different challenges we face. So I think the honesty, and going back to the point about relationships, is fundamental at the start. In terms of population and outcomes, so I'm not going to be able to give the definitive answer, but it was a two-way process. So it was bottom-up, top-down. The top-down stuff was a lot of analysis that I believe came from Hammersmith and Fulham. It looked in detail at the spend across all of the providers, health, social care, and tried to map it against what were sensible groups. There was also a bottom-up process which was done through consultation and through the working group for population and outcomes, which has averaged 20 to 30 people from across the sector, to say what would be the organising logic, what would make sense as groups if we were to think about how organisations would come together. So it was a scientific approach. But it was also a consultative and an iterative approach. And I think what we recognise is there is no perfect answer for this, but what we felt was we've got something that's good enough to help and to provide a framework for the boroughs and the localities to take that forward. And going back to, I think your last point then was about the money that's attached to that. This was supposed to be a framework, again, going back to that point between North West London and the boroughs. It's a framework through which then localities take it and challenge the way they're working and then put money to it. So it will be different, I believe, in each of the boroughs. So I can't give a definitive answer.
But the general rule of thumb is that 5% of the patients use 50% of the resources,
yeah.
right? So,
and that analysis
that seems to hold everywhere. So
exactly, and that analysis that underpinned it will be available, I believe, on the Toolkit website. So it'll be there.
Tony, any last word?
Yeah, very quickly. In terms of the tensions around the table, they are real, they are evident, and I'd absolutely agree that we've all got to be prepared to take a risk that we may not be the shape and size and look that we are in 5 or 10 years. But there isn't anyone who a year later, and we just had a meeting last week, who isn't still coming back to that table. So despite the fact it feels uncomfortable, it also feels liberating, I think, to be able to get a group of people who can focus on a particular population rather than their own organisation's four walls. So I think the people around that table have that mentality. I think the issue on regulation is a really interesting one, and one that we haven't even approached yet. There's two things that stand out about that, of course. One is from a compliance point of view with Monitor. They have taken the view, of course, that they are responsible for monitoring the risk and compliance of organisations as a going concern. So they like something very tangible, as you know, and 4 walls around it. It's a box, and they can see and touch and feel and understand it. The level of complexity we are talking about is probably not something they have considered, or indeed the Competition Commission. But what I would point out at the moment is that irrespective of the regulators, I think this is something we've got to eventually have a conversation with them on when we understand how it changes the business model. But I think this goes back to the tensions. We shouldn't hold back from changing the business model. We need to do the right thing. And then we need to approach the regulator to follow suit and help them understand how the environment is changing, but not be held back by the fear of making that change, because it might in some way encroach on their understanding as to what complies and what doesn't. So I don't think we've addressed that yet, and it's another of those works in progress that we'll have to take forward. And I probably just should say, do take it away as an accountable care group and not an organisation. I wouldn't want the Competition Commission ringing me to say we've done some sort of merger.
You might want to change the O on your slides. Judith, last point, or...
Just quickly on that, because I think this is a really important point about the regulatory context, but I think the one thing I would say is that, you know, regulation isn't there to stop innovation. So I think the important thing is that you're able to undertake that innovation in a thoughtful way, and critically within that, to be demonstrating what it is, again, what it is you're trying to achieve and what you are doing. Because indeed, I think we all know that the kind of what it is that a hospital does and what it is that general practice does and social care needs to actually evolve. I think that's what you're fundamentally about here. But not to be naive about the fact it will be challenging, and it'll probably be some of the interactions with those sort of organisations that will be the real, what's the word, you know, the testing of how ultimately how robust what it is you're developing is.
Thank you very much. So we need to move on. Let's say thank you to the panel. Let's get the next panel up. Thank you very much.